And when the individual is served with those papers, what's been written is going to be given to the individual. So it's not like you can do it anonymously. They're going to read it, and it's hard on family relationships, but sometimes it does get to the level that it needs to be done. And sometimes you can find someone else that can file on them. I think Julie does that sometimes, steps in and files just to kind of help families to not always have to do it. But it's a tough process, and doesn't answer all the problems. But when it's to that level and we just really need to get someone help, then there is the court that can pursue that and actually, mandate that the person has to follow up. So
is there a difference between age? So if they're less than 18 years old or older than 18-year-old, is there a difference?
The process is the same, where what Julie was talking about, requiring 2 statements. And it doesn't matter if they're young or old. And I've had kids as young as 5 and adults, up into their 90s. So it's a wide range, but it's still the 2 statements that are filed with the clerk of court.
I do want to add in that we as physicians and nurses can do what's called a 48-hour hold as well. So if your spouse is suicidal, you get them to the ER, they don't want to stay, but there's obvious signs that they're suicidal, self-harm, and it's a legitimate threat, then you don't have to file with a court and write it all out. A physician and one other provider can file with a judge, and the judge will give us an after-hour hold for 48 hours, and that's 48 hours, and they're there until they're evaluated by mental health, whether it's a psychiatrist or nurse practitioner, and then there's a hearing before they can be discharged. So that's another way in crisis that you don't have to go to a courthouse and file a committal or go through Julie. They can come to the ER and get that there too. But to answer Mayor's question, I think so much of we wait until we're full crisis mode in mental health instead of some of that recognizing of, we hear so many times by the time they get to the ER, well, they've been struggling for 6 months and this one thing kind of set them over, or especially with substance abuse, and a lot is different. There's a lot of overlap, but there's also difference in what help can be done. If you don't want to quit drinking, doesn't matter how many people court order you to quit drinking, the day you leave, you're going to start drinking again unless you want to quit. So there has to also be some self-ownership in that. But if you have a child who's struggling, get in with their primary care provider, get in and seen and go to those appointments, advocate for what you're seeing before we get to self-harm and needing emergent hospitalization, because there's a big gap between depression, anxiety, and a 48-hour committal to the hospital for a crisis stabilization. So early intervention is really the key. Is it family counseling? Is it couples counseling? Is it individual counseling? If your elderly parent is struggling with depression, going to those appointments with their doctor and explaining what you're seeing, because everybody says they're great if they don't want treatment. Grandma says, I'm fine, I'm doing great. But if granddaughter's there to say she's sleeping all day, she won't get out of bed, won't take her medications, very depressed, withdrawn, refuses to see people, that helps the provider provide appropriate care before we get to acute reactions. So the more you can advocate for your family members and being involved in their healthcare as much as they will let you is the best way for early intervention and not having to get a judge involved.
So I would say we do get a lot of phone calls from not just our community, but surrounding communities. I don't know what to do. Those calls get filtered through to us. So we really talk through with the individual. A lot of times it's not the actual individual, it's a parent or it's a family member not knowing what to do. Yep, a coworker. So we talk through the basic things. Do you feel like this person is immediate danger to themselves or someone else? If they say yes, then we advise that they either call 911 or take them to the closest emergency room. We do get a lot of, well, we'd rather drive to Ames. please don't. Start off at your local emergency room. That's what's safest for everyone. If it's not, a lot of times either myself or the nurse case manager will take these phone calls. I a lot of times like to ask for people's emails because we'll talk through so many things on the phone and I'll give them so many suggestions. And so I will say, hey, is it okay if I email you? Just some links to some different resources. That way you have my contact information and you don't have to call the hospital switchboard. You can just call me back directly if you have any questions. And I just go through and provide who's ever asking me with links of what they need. You know, maybe I need to find a therapist or my child needs to get some psychological testing. Where are the psychologists? What do I do? Lots of different questions like that. So again, we kind of decipher through, we get these calls as an emergency or if it's not. A lot of times it's not, hey, maybe like Dr. Fulgrad mentioned, we're noticing that this is starting. So we'd like to get help. So we education with those calls that we get.
So you mentioned that people call you, and then Jenny presented on the 211.
Mhm.
What do you recommend? Because I think it can be confusing. Do I go to 211 and do a search?
Yeah.
Do I call the hospital? Do I call 911? What would you recommend? Because what I heard you say, obviously you have this experience, which is outstanding. I'm not trying to discount it, but just curious, what would be the recommended path to follow?
So when I mentioned that email, I would email, maybe it's contact for 211. Maybe it's a link to NAMI. I always include in there, this is how you reach Archer if it's someone in Ames. You know, you could call 911. This is how you access mobile crisis. So I like to include links to different things, not just the mobile crisis number, but how can they help me? So I really would try and encourage that person to have community resources and a nice list of them, and maybe what each one can do to help them.
And this was not an application for turf battle that don't call you. I'm just trying to make sure we're all on the same page because I think that we want to make sure people know that there are lots of good resources. So 2 questions for Julie. One is, this is a great segue into potentially mental health first aid training. That might be something coming up in the future. And
Yeah.
also, I'm a little bit shocked to think about homicidal thoughts, not just suicidal thoughts. If you could just comment on that too, as
Sure.
because you see everything.
Yes. So we do have people, obviously, that are struggling with suicidal ideations or actively wanting to take their own life. We also have folks that are in a mental health crisis that may be homicidal, meaning that they actually are making statements that they want to harm other people. Very specific how they want to do that. So that is the 2 criteria in the state of Iowa that would have a judge sign off on that involuntary committal. But again, for both, the 2 people that are the signatures have to have direct information. And what I mean by that is that you have heard that person make those statements. You have read that with your eyes. Maybe it's on social media, but you have direct knowledge or information about what that person is saying. Kind of to piggyback off of what Susan said, I actually do the same thing that she does, just with the police department. So I have people calling me as well all the time wanting resources. Same thing. I do the same thing that Susan does. Give me your email because it's much easier for me to share that information. It's a lot of information. 211, Irely Ball, Mobile Crisis, Arch, CFR, primary healthcare, whatever that person is sharing with me, I'm giving them a list of those appropriate resources. The other thing that I can assist with when folks are calling, I'll ask them what kind of insurance they have so I can kind of filter out, okay, who are we going to connect you with? So I'll help out with that as well. But education, so incredibly important. I say this for many reasons, but number one, 1 in 4 people will be diagnosed with a mental health condition sometime in their lifetime. And I would probably say 1 in 3 at this point, given COVID. So we have a lot of people that are struggling, a lot of people struggling with substance abuse. And I really do believe it takes a community in order to be able to help out all of us, really. I mean, we're all touched by mental health, substance abuse, whether it's us or somebody that we know. And although we have amazing providers here in our community, it really does take a community to be able to help and to support and be there for people that are struggling. So I would say that if you're looking for some really great education, mental health first aid is fantastic. It is an 8-hour course, and it covers a variety of mental health diagnosis, their signs, their symptoms. How do you respond to somebody that might be in the beginning stages of mental illness, or you are noticing somebody is struggling with substance abuse? Also, on the flip side, how do we respond to somebody that might be in crisis? So we kind of cover all of it, which again is a great class. Susan and I teach that class together along with the 2 advocates at Iowa State University. Do we have any other people up here that are teaching? No? Okay. I just want to make sure that I get you guys. This is a free class that we put on. So I want to make sure everybody knows that. Was it a year ago, we did in the summer 3 community mental health first aid classes. I think we're probably going to be looking at doing something again like that to be able to educate our community. There's also QPR, there's ASSIST training. That is a 2-hour training that is designated to suicide training. So keeping someone safe for now. Because we have people who struggle with suicidal ideations. Maybe they don't meet criteria to go to the emergency room, but they are struggling. So how do we talk to that person? How do we broach that topic? How do we keep that person safe for now? Again, I am an instructor. There's multiple instructors here in our community, and that also is free. So we want to make sure that we're educating everybody.
So just want to add, Julie and I are actually teaching mental health first aid next week at Mary Greeley. We have open seats. So if you are interested in signing up, it is May 11th and May 12th from 8 to 12 at the hospital. So it would be free. So if you are interested, you can come and see me afterwards. I can give you my email. I think we have right now like 7 open spots. So yeah, I'd love to talk to you about it.
Yeah, last summer we had some evening classes too, and we're going to look at that too. So we had over 120 people take advantage of that last summer. And I know there's been a lot of training done in addition since then. So, all right, so we're gonna have more question opportunities at the end. I want to transition now into allowing our panel experts here and just sharing what resources you offer. And if you would, maybe you could also touch about we have a substance use is also a class. We talked a lot about mental health. Not that substance use is not part and parcel of that, but if you provide services or can comment on that also, and we say substance use specifically, not necessarily abuse, and we know that those substances can vary from alcohol to a lot of other different things. So if you want to just go ahead and go down to share what the services you provide, and maybe how you would plug in with some of what's been shared so far. So please start.
All right, let's start with a new guy. So at Eyerly Ball, our community mental health center, our office is located just south of 30, probably wrong in my directions here, on University Avenue. And so if you enter our community mental health center, when you first enter in, you're going to be connected with one of our client service reps. And so they will begin your journey, your navigation for family, friend, coworker, whoever it is that maybe you're helping to support them walk through our doors, or it may just be someone that, you mention us and they come in on their own. Once they meet with our client service rep, we have a position that is called navigator. And it really is, it sounds exactly, they begin to help navigate that individual or that family through the system. It was mentioned earlier, the system is challenging at times, it's frustrating, it's confusing. So to have somebody there to hold your hand and help connect you with other providers. One thing our navigators are great at is if we don't do it, we're going to connect someone, another provider with you. So we're not, I know territorial, whatever words were brought up before, but if you have a son or daughter, an adolescent that would benefit from services at YSS or another provider, we're going to help get you there. And the other part is a lot of people walk through our front doors thinking they need a evaluation or a med assessment, and our navigator can start getting into some questions. And many times it was brought up, what are things to look for? Many times individuals are struggling with housing issues or food related issues or work skill development support. And so our navigators can also then be connected with the individuals. You may not need necessarily to go in for an initial assessment. Ultimately, you may need that, but we can also help steer and navigate you, so to speak, to the right or the most, might be at that time the most logical next step. It might be connecting with a food pantry, things of that nature. So once you've connected with our navigator, then if a initial evaluation or assessment is appropriate, then we will do that same day access, and you will see one of our intake specialists for an assessment. If you're there for a med prescribing assessment, then we do have on site our ARNP PA staff that will complete that initial assessment. Our challenge right now, and I think we're on Facebook Live, so I can use this as free recruitment material, right? Is we're always looking for licensed individual, our independent social workers, LMs. And so our biggest challenge right now is keeping our chair full. So on multiple times a week, we have individuals coming up from Des Moines that will carry a caseload. They'll also be part of our same day access programming. But you will then get on that schedule. So once you complete your assessment and evaluation, we will then you'll be connected with our therapist for your next visit. A challenge or hurdle right now within our industry and our system is how far out your next appointment is. And so that's also part of our reality aspect too, is if it's more beneficial to connect with another provider, we will help you do that as well. So that is our clinic aspect from a mental health perspective. On the other side, I say the other side because you walk across the hallway, but the other part of our building, we have multitude of wraparound community-based services from IHH to mobile crisis, which was referenced earlier. We have some amazing individuals who you may very well run into just through police calls, might be a connection through Arch and other provider partnerships to where they'll be interfacing from supported community living, daily home visits, things of that nature. So that is what we offer. But from the simplest perspective, as a community mental health center, you walk through our doors and we're going to start you on your journey to receive the appropriate level, the needed level of mental health care at that time. So I'll just kind of stop there and answer any questions, or at the end, I think you said, we'll keep going.
Great. Are we going to have slides, Deb? If we don't, it's okay. We do this all the time without them. So,
while you're waiting,
Yeah.
how do people get to Ironly Ball?
As far as where to find us,
How do they get referred to you? Is
Yep.
Does Julie refer people to you, or does the hospital, or how do people get into?
so we can be as simple as a walk-in clinic. So let's say you hit 211 or you through word of mouth, you can just walk in. We're open at 8 a.m. And so you can start that journey on your own. You don't necessarily need to have that referral, but we also collaborate with our provider, our community partners, that they will make referrals. One thing I would say is if someone close to you is looking to excuse me, walk through our doors. The first couple of times, first time for sure, if you can accompany them, that's usually the toughest door to open, is that first one. If someone that you're worried about is like, yep, I'm going to go there tomorrow, go with them, help them. Look at it as no different than I got a toothache and I'm going to the dentist, or I'm going to something physical health related. But if you go with them, that will help them kind of relax a little bit, but also they can start to see that this really isn't, although sometimes when it gets to the crisis and emergent levels it is, but it shouldn't be viewed any different than going to your physical health provider to worry about a toothache or, aches and pains within your body. It's just a different door that you're going through. So, but they can just find us and walk through.
As I said earlier when I introduced myself, I am a service coordinator at CICS. And as this gentleman asked, everyone does. What does that stand for? Because whenever we see acronyms, we want to know. So it stands for Central Iowa Community Services, Mental Health and Developmental Disability Services is what we're all about. Next slide, Deb. So we are the 15 county region here in central Iowa, the mental health MHDD region. So maybe the next slide. I want you to get a visual of what this means. So there are lots of regions in the state of Iowa. Back in 2014, the governor gave the mandate to all counties that they had to join together to form regions. And the purpose of the region is to oversee mental health and disability services, and specifically to really oversee the non-Medicaid funding services. So we are not an agency. We are not a service provider per se. It's like most of these folks up here are a provider of a service. So if you call them, you're going to make an appointment to get a specific service. CICS doesn't have therapists or nurse practitioners or psychiatrists. So if you call us, you're not going to get an appointment to see that at our office. Next slide, Deb.
When are we going to get them to call you?
Well, that's what I'm going to tell you. Good question. So what Nikki and I do is called service coordination. So as service coordinators, I think the easiest way to think of us is we're the information and referral people for non-crisis services. So these folks in panel one, these are the experts in if there's a crisis going on. If there's not, if you or you have a family member that is maybe been having some struggles with anxiety or depression, maybe they have recently been diagnosed with a brain injury, or maybe they've been suffering for lots of years with a developmental disability or intellectual disability, and it's maybe time to explore what's out there as far as services go that we can get. And when we're talking about the services that Nikki and I help people to access, we're talking about a continuum of services. So everything from those lower level, like Irely Ball just talked about, those community-based evals, psychiatric services, therapy services, all the way up to very high level support services, things like residential group homes, staff department sites, employment services. So there's a whole array of services that are out there in the community. They're not emergency kinds of services or crisis services, but they're support services that people with disabilities are going to need to live their best life. So that's what you get when you call our office. You get Nikki or I to talk to you as a service coordinator about what your needs are and what kind of resources and services there are in the community that might help you to meet the goals that you have. So I'm going to pass it on to Nikki. She's going to talk to you about how those services get paid for, because none of them are free, unfortunately, but there are ways that they get funded.
There we go. Yeah. So
different services, there are different funders of those services. Sometimes private insurance, Medicare, Medicaid can pay those things. Sometimes Medicaid programs, we didn't put on their waivers, but HCBS waivers, we can talk about that if you call us, is also a funder of services. And then mental health and disability services regions. Next slide, please. So if you contact us and we help determine that some additional long-term funding is needed or funding for support services outside of, your insurance can provide, then we look at our funding eligibility. For adults, we're looking at a qualifying diagnosis, residency, income, and resources. For children's behavioral health, we're looking at a qualifying diagnosis, residency, and income. And then we just kept this very brief due to time, but if you have any questions, please do not hesitate to email us, call us. We forgot to give a shout out about Tyler Lennon. He is our justice involved service coordinator. So he is actually connected with the Story County Jail, and he can meet with individuals or inmates who have identified a mental health concern in their history or would like support in looking at services as they transition back to the community. So it has all of our contact information. Another great resource is our website. On there, it explains in a lot more detail about the types of services we briefly mentioned, and just gives more detailed information about what are those, what does it look like, and also has our contact information on there as well. You can connect via email on there. So very easy ways to connect with us. Anyone can access service coordination. It is a free service for anyone in the county or in our region. We also have some items in the back, so brochures and just a few other things that help explain some of those services as well.
All right. So like I said before, I'm Brittany Rice. I'm the outpatient substance abuse supervisor for community and family resources here in Ames. So we actually offer a lot of different services, but to get started with us, you're going to do a substance abuse evaluation, or you're going to be referred from a different agency where maybe you've already done that. So we do offer same day access evaluations on Tuesdays, Thursday evenings, and then Fridays. So you'll come in, you'll do your paperwork, you'll meet with a counselor, you'll do a drug test, you'll get your evaluation completed. And usually you're going to leave with those recommendations. Sometimes there's complicated cases, of course, that need to be talked about with the clinical team, but you'll get your recommendations after that. Once you complete your evaluation, you will be scheduled with a counselor or set up with a bed date if you're going to residential treatment. You'll go in, you'll see your counselor, you'll admit, and then you're going to start your actual treatment sessions. Typically on an outpatient, with an outpatient client, we are going to schedule group sessions. So we offer 2 different levels of care here in the Ames location. We offer the level 1 outpatient, which is the lowest level of care. That typically is 2 groups a week in an individual session once every 30 days with your counselor. Typically anywhere, at minimum, typically it's about 8 weeks. It can go longer though, depending on the person's need. And then we offer a higher level of outpatient care, which is called intensive outpatient. And that is exactly what it sounds like. It's intensive. It's 3 3-hour groups and an individual every week. So it's 10 hours of programming a week. You do that about a month-ish, depending on the needs. And then you typically go down to a lower level of care. We do offer other services under the substance abuse side. We have a couple of grants. We've got our homeless grant that a lot of people here on the panel are familiar with, and refer people to. So that one is pretty cool. We've got a case manager on site that helps with that, helps them get hooked up with the different services. We've been able to house, I think, around 17 people since this case manager has been with us, which is a big deal. And then we also have our state opioid response grant that can help fund a lot of different things, including actual treatment services, therapy, clothing and hygiene. I actually just paid someone's rent today. I'm super excited about that. So different things like that. And then we also, under my side of the agency, have our gambling treatment. We have a gambling counselor who is based out of Ames. And it's a similar process to get into gambling treatment. However, we do not offer walk-ins for that or same-day access. You would call and we would get you scheduled with the counselor to do the evaluation and then to do your treatment services if that is a need that you have. And with that, I'm going to pass it. What? Oh yeah, sorry. We do have a MAT clinic, medication assisted treatment. That is within our office. It's through UCS. People can start off with that by giving us a call or giving the MAT clinic a call. That number I don't know off the top of my head, and I apologize for that. We have a MAT nurse on site Monday through Friday. Typically, people start off dosing with their medication-assisted treatment daily and then can go down to weekly or biweekly, depending, again, on the need. I think that covers everything on the substance side. I'm going to pass it down to Carrie now.
So mental health with community and family resources starts with, again, a phone call, an email through our website, a referral from a provider in the community. We work very closely with many providers in terms of like, what services do we offer? What do you offer? And how can we wrap services around a client? So you'll come in and we offer both mental health as far as therapy. So if you're wanting to talk to a therapist, we can get that scheduled. And again, just like Bill said, I think everybody has a concern around not enough workers. So that is just community-wide, that is statewide. I think that's nationwide. We also have psychiatric providers that you can schedule appointments with for medication management or medication evaluations. And so basically our agency works hand in hand with co-occurring. If you have concerns around mental health, we can see a therapist or a psychiatrist or a psychiatric provider. If you have substance use disorder or substance use, we can look at that. But we can also work with folks that are co-occurring or what we would call multi-occurring. So any screening that we do, no matter where you walk through our doors or how you walk through our doors, is going to include a short gambling screen, a short screen for alcohol, a short screen for drugs, and a short screen for depression. And that helps us also kind of be informed of what the needs are and what kind of services we can wrap around a client. We also do a daily living assessment. So we will also screen for housing, food needs, and again, make those referrals and help navigate those. I guess I should ask, Brittany, did I forget anything?
I don't think so.
Yeah. So, you're welcome to contact us at cfrhelps.org or give us a phone call or yeah.
As noted previously, my name is Spencer Blake. I'm the residential counselor at Youth and Shelter Services at the Youth Recovery House, which is just about 2 blocks north of the library. So right in the heart of Ames, but I primarily work in the residential side, so that's what I can speak on the most. But I know outside of that, we obviously offer outpatient services, intensive outpatient services, shelter work. But speaking more so on the residential side, we work with teenagers ages 13 to 18, working to get referrals from parents, outpatient providers, juvenile court services in regards to their concerns regarding clients with substance use disorders. So initially having them come in, getting their referral sent in to our admissions coordinator. From there, her as well as our program director and our clinical supervisor work to look over their case, work to see, what their needs are, what their situation is, if they fit criteria in regards to the substance use needs. We work to, get them scheduled in for admissions. And then from there is a little bit more of my work as counselor / case manager from start to end, creating their treatment plan, as well as working to do individual sessions, working to get them set up with our in-house mental health therapist, and then working to obviously have med management going. So working with one of our doctors or ARNPs to make sure on the medication side we're doing everything that we need to. And as they work through the phases of our program, there's different varying things that we work to do. So once they kind of are getting along in the program, we'll work to start family therapy as well with clients. 4 times a year, YSS Residential runs a Strengthening Families weekend where we'll have all clients' families from our youth recovery house for our males and our 712 house. We'll have 2 separate weekends in regards to having all families down, working through the curriculum that we work to do to be able to give them all the help that they need, followed by, additional supports such as our every first Thursday of the month. We currently have a parent support group in regards to current families within the program. And then come the first Thursday of June, we'll also be working to have an additional 45 minutes in regards to past parents to be able to make sure we're working to give them support in regards to, what may be going on in the home, after they've obviously discharged. And then once it comes to kind of the end bits of program, making sure we're touching base with juvenile court services, usually reconnecting them with their previous outpatient provider, connecting them with mental health, medication management, schooling, and everything in between that they need from there. And making sure, that transition from residential, since they've, our program is based 90 to 120 days. And then at the high end, they may be there for 6 months. So that transition can be pretty tough once they've been in the same environment 7 days a week, for the last 3 to 6 months. So between visits, family therapy and everything, trying to make that transition from one area to the next to outpatient as smoothly as possible. So I think that's about it.
Thanks, panel. And this is just a cross section of what's available in Ames. There's a lot more groups that are available. One question comes to mind is, so how do I choose who to call? I know that CICS, you're kind of like a traffic cop, it sounds like. So is a first call to you, and then is there duplication of services? Because I think I know Spencer. YSS I think is up to 25 years old and younger, right? So a 35-year-old is not going to necessarily be getting services, although they could through the family side.
They get mental health services at YSS.
Okay, so we have Jenny had to leave. But we have 211, which is kind of trying to, I think, help point you to some things, but help people who. I think the people you can appreciate when people are really struggling, they're just wondering, who do I call to get help? So just maybe you can briefly just share, some suggestions on what you would do or what you would recommend.
Yeah, I can start. So at CFR, at least in the Ames area, we do primarily serve adults. However, we will serve adolescents on occasion if that particular person or family wants to be served by us. Our mental health side, they do some play therapy and things like that. So they do serve adolescents and children as well. We get a lot of our referrals, at least on the substance abuse side, from probation officers, DHS workers, and things like that. So a lot of times they're sent to us. However, we do get some calls or people reaching out from Your Life Iowa. That tends to be a fairly common referral source as well. And so it's just they'll log on and they'll click what they need. They'll put in their zip code, and then they might reach out to multiple different locations. Oftentimes we'll get an email saying, oh, this person agreed to have these different agencies contacted. Please contact these people and see if you can get them in. And then we'll give them a call. So that's some of the ways. We also get calls from people who are being referred to us from their doctors. And then I've had other people be referred to us from their actual mental health therapists that are external from us as well. So a lot of it really comes down to maybe they've had past experiences with us. Maybe they just, they are comfortable with us. They know the providers and things like that. At least that's what I see. We see a lot of people that are like, oh, well, so-and-so went here and they liked it. They liked the counselors, so they came in or something like that. Or their probation officer is like, hey, go to CFR.
So you mentioned Your Life Iowa. What's that?
So Your Life Iowa is a website. It is similar to 211, but not exactly. They don't necessarily talk about like the food and the clothing and things like that. But it's a website that you can log on to at any time. It does have crisis chat and a phone line that you can call. Or of course, like I said, you can submit a request. Typically there's like a little survey or screening that you would do, and then you would input your information so that they can get somebody contacted with you. So here in Iowa, if you called the 988 number, you would get in contact with Your Life Iowa crisis counselor, and then they would hook you up with who you needed. So we've had calls from that as well. That's also like if you called 1-800-BETS-OFF, you would go through to Your Life Iowa, and then in this area, you'd actually come through to CFR. So I hope that answers your question.
It does. Anyone else want to add anything, Bill?
I would add, there is no wrong answer. I would say reach out to somebody, start somewhere. There isn't a right answer. There isn't a wrong answer. Reach out. And if they can't provide the services, they'll connect you with somebody that can. If you make connection with a therapist and it's just not the right fit, don't stop. Find a therapist that's going to be a good fit for you. There's no wrong answer here. I think our only concern is we have to reduce the stigma and say it's okay to not be okay and it's okay to reach out. Yep. And there isn't a right or wrong answer as to who to reach out to.
I think I just want to say that there are other services people need that might not be treatment based specifically. And that's where CICS can maybe be helpful. I mean, if you call Irely Ball and say, I don't have a place to live, they're going to say, oh, why don't you call CICS and ask them? Because we have that access to Optima Life Services, the folks in this area that do not treatment, as they do what's called residential services. Or we can refer people for employment services. We refer people to IVRS, Iowa Rehabilitation Services. We also have access then to do our funding ongoing at the different vocational agencies in town. You have to have a mental health or a developmental disability diagnosis to access those agencies. But we have that ability to do that. To access, to assess with people those kinds of services that maybe are in addition to actual specific substance use disorder and mental health services.
And I just wanted to add to that. So as advocate, I cover 5 counties, so I've got quite a number of clients. And so just an example to piggyback on what Kathy just had said, I had an individual whose dad contacted me and said, my son, adult son, is struggling. What do I do? How should I, proceed with this? And so my comment was, call Kathy or Nikki. And then Kathy right away within the next day or two went and met with them and was able to take the time to dive in to what services they might truly need. So that's just kind of an example of then they kind of do it and figure it out. So the service coordinators are somebody that I really reach out to in every county that I serve, just to connect people with services.
And I'll just ask one more question, then we'll go into the audience question and answer. And that is, are you guys busy? And if so, I think that sometimes I appreciate the comment. There is no wrong person to contact. I appreciate that. And also the mention was made is we got to get rid of the stigma. Absolutely. But I think sometimes to get rid of the stigma, we have to have people share, what are you seeing and how severe is it? Or is it basically all trumped up? I'm sorry, I didn't mean to use that was no intention, ginned up, so to speak, or it's not really, is it really truly an issue? And I think I know the answer, but I'd love to hear from you. What kind, not names, but what are you seeing? And is it an issue? Is it increasing? Maybe just each of you could just share briefly, what you're seeing. And Bill, you said that you're trying to use this as an Indeed site, trying to get people to apply. But obviously, you have a need for people. So please go ahead and then just go down the line.
Yeah, and I'll make it brief. I mean, so yes, it is real. We are busy. I think I would go back to the beginning, which is if somebody around you think needs help early on, the earlier you can get them to reach out. And it's been reiterated multiple times here, we will help you find the right resource. So if you come to us and it's something specific for substance use, and it may require inpatient intensive, IOP services or residential, we're not going to waste time, so to speak. We're going to make sure we get you connected to that right service. On the flip side of that, if it's something that we know we can provide for you, like we're starting groups up here in Ames in the next 45 to 60 days. So, because we also know there's a little more retention and there's strong outcomes in group work as well, in addition to individual services. So it is real. I would say the earlier you can, either yourself or someone can get them through the door, do that. And it doesn't always need to end in true assessment, diagnosis, medication. It can be, things can be prevented before you get down that rabbit hole. But if that's appropriate, then we're going to assist you with that too, just like all the providers. So it is real. And yes, keep, for those of you that are in school, keep going to school and, get on Indeed and apply for any of the providers. So.
I concur. I'm sure everybody up here is very busy. And at CICS, Nikki and I refer people all the time to these guys. So people come to us not knowing where to start and maybe need just basic outpatient. They need an evaluation. And so we help them get to one of these places. And I know it takes some time. So I know they're all very busy. In addition to the shortage that you're seeing for therapists and nurse practitioners and psychiatrists, I'm going to put a plug in for the huge worker shortage there is in direct care services. So the folks that work in that group home, the folks that do that supported community living in the community and go help people in their homes, we don't have those workers right now. There's not a single agency in Story County that's taking new referrals for supported community living, only because they have no staff to provide the service. So it's a huge problem. We have lots of people that need that service, need that kind of hands-on support, and we don't have a way to give it to them. So yes, we're very busy, and it's very frustrating when we see the need and our hands are tied. Nikki and I see it every day.
I agree. We are very busy. There's days that I don't see some of my staff because they are just continuously in sessions with their clients or running groups or doing evals. So we are very busy. As far as what we're seeing, I will say here in Story County, the highest rate of diagnosed substance is alcohol for us, followed by stimulants and then cannabis. We have seen a little bit of an increase in cocaine. Nothing too extreme there. I think it was like maybe a 4% or something like that, but it has been a little bit of an increase from years past. So that has been, coming up a little bit. And opioids continue to raise as well. So those are some of the trends that we're seeing here in Story County for substance use, at least at CFR. I'm not sure what YSS is seeing. I'm sure theirs is similar, but maybe a little different since they deal with adolescents more. But I would also agree, if you're going to school, keep going to school and then come work for us.
Yeah, so I think what we're seeing is more complexity. We're seeing a lot more complexity. We're seeing a lot more co-occurring, whether that's trauma and mental health and substance use, and that's impacting medical. But what we see is the whole person. You know, I think we all see we all try very hard to see the whole person. So that's why we do multiple screens. You know, a hidden thing is gambling. That is hidden, folks. And so sometimes, you know, clients come in and it's something different, and it really kind of boils down to, let's add gambling onto this because that's been a recreation that we did during COVID, during lockdown. We could do this. There's more online. So there's a lot of whole person, medical, mental health, substance use. You know, it's a complexity, and that complexity is what is growing. You know, trauma is a lot of times going to have an impact on substance use disorder because people don't want to talk about trauma. That's part of the diagnosis is active avoidance. I don't want to talk about this. I want to shut down. So then we see, you know, people doing some medication, self-medication with substance use. So I'm going to say it's complexity, and its complexity is not getting any easier. It's getting bigger, it's getting harder, and it's getting younger. It is absolutely getting younger.
To jump off a little bit of their kind of trends that they discussed, definitely seeing, you know, a lot of our clients, a majority, we typically end up having, you know, cannabis use disorder as kind of the predominant, but, you know, seeing a lot more intensity around use, seeing a lot more, you know, as part of my job, you know, when they come in working to do my own substance use history, drug alcohol history kind of eval. So definitely spending a lot more time on some of that stuff, just all these new names and increased use and things getting heavier and heavier, seeing more opioid overdoses and fentanyl being involved, and, you know, other substances such as xylazine starting to come into the world that make everything scarier. So definitely seeing upward trends in regards to that area. I know dipping my toe in outpatient for a little bit. Ourselves were, you know, having our struggles of having providers, so having to take some of our residential therapists and counselors to kind of help out in the outpatient world, you know, to then being a little more settled in and having some more providers. So me being able to kind of step out. One of the bigger problems in regards to especially adolescent residential is just overall lack in general. From what I know at the moment and what I've always known, there's about 3 residential, you know, adolescent substance use. There's YSS. We're working on getting our Francis Lauer YSS North Iowa set back up in Mason City, or else you're looking at Rosecrans Jackson in Sioux City or STARS in Fort Dodge. So not a lot of stuff to work with, sadly, but hoping that'll change in the future, which creates bigger problems for families when, you know, they're having to drive 2-3 hours, you know, just to be able to have a visit, and that can start to cause its own issues. So especially on the residential side, you know, hoping we can start making a little more change in regards to Iowa, but as a whole, whether outpatient, residential, whatever programs, you know, just hoping we can get a little more help as much as we can.
If you want to pass the mic down, I think Julie wants to jump in. Maybe Dr. Flugred and Susan might want to just share a little bit of what they're seeing too before we go to questions.
I'm going to give you some statistics here. But before I do that, I just wanted to quick say that when I came to the mayor a couple years ago and said, let's do these community conversations, we want to educate the community, right? And we need to make sure that we're talking about hard things because people are going through a lot. We need to make that okay. But I also wanted to make sure that when we have these conversations that not only are we providing education and showing our community what we do have, but I want to have real, raw conversation about what's really going on in this community. Because if we don't know, then we can't do anything about it. And sometimes it's not pretty, but we have to speak truth. So what I will say is that when I first started 8.5 years ago, these are my statistics that I keep. 805 mental health calls that I responded to last year was 2,700. I probably responded to 2,400 of those. Those are just my statistics. That's not the Ames Police Department. That's not Iowa State University. 20% of my 2,700 calls are people that I responded to that are actively suicidal. 20% actively suicidal, and that is here in our community. That is incredibly frightening. I think we all can say that we're seeing a rise in folks that are suicidal, and certainly our kiddos are really, really struggling. 11 is actually the median age for someone to develop an anxiety diagnosis. I would say we're at 9, age 9 at this point. We do have amazing resources, and I'm going to keep saying that. And everybody up here, we're all doing what we do is because we care and we want to make an impact on someone's life. I will tell you, I am exhausted. I am exhausted, and I'm very sad at what I am seeing from my lens. So I'll keep saying education, education, education. We really don't have enough people. We just don't. I don't have the answers for that. I'm not even going to get into that. But it is what it is. So we really do need everybody here in this community. I really mean that. Get to know your neighbors. Start having conversations, not just texting. Start going out, having coffee, asking somebody, how are you doing? No, really, how are you doing? And asking it a second time. Because when you do that, and when you are holding space for somebody, you're allowing somebody maybe to tell their story. And then maybe you can be that person, and we don't get into those crisis situations. Or you can maybe be that person to educate yourself on the resources here. Or you can say, I know somebody that can help you. And I'm not saying, when I say I'm exhausted, I'm not trying to be negative when I say that. I just want to be really realistic here of what we're all seeing, right? I hate going home and knowing that I tell people all the time, I'm sorry, I can't help you. And what I mean by that is, it is not the people that I am working with, it's the system in which I work within, right? So I can't do a committal, and I'm sorry that your loved one maybe has psychosis, but there's nothing that I can do right now unless, one, they want help. I can point you in the right direction. Maybe you can't get in for 6 weeks. That's really hard. But I'm very grateful that we are having these community conversations. Again, one, you get to see all these amazing things that we have in our community, but also I'm so hopeful that all of you will take an opportunity to really think about, what can you do for our community? Even if it's just you reaching out to somebody and saying, hey, how are you doing? Maybe it's a coworker where you're like, hey, I noticed that you're kind of quiet. You've been that way for a couple of weeks. Are you doing okay? You don't know what kind of impact by doing that you really make on people.
Well said, Julie. I'm going to defer to the hospital folks on this.
So really what we are seeing is just a struggle to get patients in for follow-up care in a timely fashion. And by that, I mean not months out. We are lucky that providers will sometimes save crisis spots for people coming out of the hospital so we can get them in a little bit sooner. Even still then, we're looking at usually 3 weeks. We also get a lot of patients who said, I just couldn't wait anymore. I reached out to get help. A therapist can't see me for 3 months, and I can't get in to see a psychiatrist for this amount of time, and I just got tired of holding on. That's pretty common for us to get that response from people too. Again, we have amazing providers. We just don't have enough. So we really struggle to piece together a plan. What's this going to look like for this person? Are they going to see their primary care provider? Hopefully they can see them within 2 weeks. Is that going to be enough time to fill the gap till they can get in to see the psychiatrist? One of the things that we really like to do is make sure everyone knows, and we don't have this in Ames, unfortunately, but are the behavioral health urgent care walk-in clinics in Des Moines through Unity Point and Broadlands. We tell people if you can get down there, if you can have someone take you, that's an excellent resource too. And again, it's just education, 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 because it's really hard for people to hold on. It's hard for them to wait and then they're coming to the hospital, or it's hard for them to know that, hey, when I leave here, it could still be a while before I get to see someone. And that's probably one of the biggest struggles that we have. Again, we have a lot of the same similar things. We have people with housing insecurities, food insecurities. So we work really hard to not just to say, hey, I'm going to set you up with your behavioral health appointments, good luck. It's okay. So where can you go to get food? Where can you go to get clothes? We help people do the initial housing applications, SIRHA. We refer people to Voc Rehab. So we try really hard as the case management staff to really look at that big picture and make sure that we are helping people in every way that they need help.
Okay, we have our first question.
Yeah. I will also say too, to follow what Susan said, that's part of the purpose of ARCH too, is that they will help get people connected to resources, even if it's homelessness for sake of discussion. It's not just necessarily going to the hospital, it's helping them get need resources. Yes.
Mr. Mayor, can I put you on the spot?
Which one?
Can I ask if your office could or has done a study of other cities or similar communities where there is adequate mental health services available? Second part of that question is, and then determine what kind of extra tax structure you would need to support to get that done. And then third, I'd like to do a quick review of each of the persons and ask, other than substance abuse, what are the 3 mental health problems that you're seeing the most currently?
So no, we have not done a peer city review on what they're doing. I do know that we have phenomenal resources here in the community and are working extremely hard to try and
I'm not putting down anything.
No. I didn't take it that way. I honestly didn't. Yeah, I'm just trying to respond to a really good question. So could we do that? We certainly could, but no, we haven't. So we haven't done that. Secondly, in terms of tax, what it would take for taxes, you pose a question which is very raw for me right now because the legislature just passed a bill today that will be potentially restricting our taxing ability for services. And so consequently, council, and I appreciate Tim Garten here, one of our council members is here, we'll have some very, very serious conversations to be having going forward because this all falls into, a big bucket. So now your question for each individual was, could you restate your question?
Other than substance abuse, what are the 3, other than substance abuse problems, what are the 3 mental health problems you're seeing the most, and has it changed very much? Just quickly.
I don't think it's really changed, just an increase in total numbers. It's still, at least through the ER, depression with suicidal thoughts, anxiety, panic disorders, and they may not be truly substance abuse, but so it might not be an addiction daily, but the overdoses, especially related to fentanyl, being in almost everything now. So kids think they're just smoking marijuana. It's got fentanyl. So
Anybody else want to add to that, or does everyone kind of agree with that?
I would add post-traumatic stress disorder. And I would add that untreated post-traumatic stress disorder in childhood creates a lot of diagnostics on the adult side, whether that be bipolar, substance use disorder. So I think that we have to look at post-traumatic stress disorder, even way back into childhood.
Thank you.
I think also I'd like to add here that we don't, Nikki and I don't diagnose people, but we help people get diagnoses. But I think that the most frustrating issue that we deal with most commonly today that is directly related to mental health and the folks we see is homelessness. We have a terrible homeless problem in this city, and I think a lot of people don't realize that. We have a wonderful shelter, but they can't house that many people. And a lot of people with very severe chronic mental illness can't be in the shelter. Their behavior is such that there's a no contact order against them at the shelter, and most businesses in town, and they need a place to be. Everyone deserves a home. It is extremely difficult to be seriously mentally ill and be homeless. You can't take your meds on a regular scheduled time if you don't have a base of operation. If you have to constantly be worrying that somebody's going to steal your meds, which happens all the time to homeless folks. So it is a problem. Even when we manage to get people on programs like permanent supported housing and rapid rehousing, we have a shortage of landlords in this town that are willing to work with those programs. Our folks have a lot of reasons that make them not good tenants. And so it's the biggest issue that Nikki and I work with. The calls we get most frequently are, this person has no place to live.
Thank you. Other questions?
I appreciate the way you're all working together. Is there a space for volunteers, for people with some training? I've taken the mental health first aid. It is an amazing class. Is there a place for people with good intentions, a good heart, and some training that could volunteer and help out?
Next question. No, I think the question is actually, if there is, what are the opportunities?
I think for some of the positions, and I know probably down with YSS would definitely have need in residential as well. But like our SCL, our supported community living, I think sometimes people think, oh, I need a 4-year degree, I need a sociology major, I need all these things. You don't. And some of our best workers have life experience, and that's really the best thing of their resume. So I would say, yes, there's mentor programs. We also have paid positions, that part-time, and it doesn't have to be full-time. And I think all the providers have those, whether it's direct support staff in the community work, there's a huge need for that. And we'd be extremely excited for individuals to call us.
I know I've heard Andrew Allen say that they're always looking for mentors.
Yeah.
And primarily more in the male side than the, men than women, but not that you can't have both. I know that Nicole Patton she's one of the associate vice principals at Ames High. They're trying to connect each student with an adult, also to have someone they can trust. They're trying to do that within the campus itself. So in other words, so it might be a teacher or a counselor or administrator so they can go to somebody. But I think that the more we can do to come alongside and volunteer and be a safe person to engage with is really important. That's a great question. And that's probably the reason for these conversations is to bring it to a light. And I think that no one's going to be turned down. Other questions?
First of all, I just wanted to thank you all for what you do. I work in direct care, so understand how hard of a job this is, and just thank you for all that you do. So I had a specific question about Arch and the mobile crisis unit. Are those the same thing now? Are they different? And when would you use one over the other?
Great question. I'm going to let I think there's a time factor too. So go ahead, come up here and you can start. And then,
So Arch is through 911 only, and it's Ames only. So the city of Ames. So mobile crisis is, I want to say statewide. Is it statewide now? Statewide, yeah. And 24/7. Arch is currently 8 to 4, Monday through Friday. So the difference would be just, I would say it's accessible to, mobile crisis is accessible to the whole state and 24/7. But we still crisis. Yeah.
I would agree. And I would just say, we have folks placed throughout the state. So if there's crisis in Mason City, that person, or Hardin County, or wherever it may be, we partner with Arch as much as we just, we're still connected to law enforcement, correct, in those responses, but we're statewide.
I'd say speed of response too, is that mobile crisis is a phenomenal program, but it does take some time. It may take them up to 45 minutes to respond, only because of that. I think I'll let someone else, fill it in. Whereas Arch could be potentially a fairly short response time. And, pardon me? In the city of Ames, right. And also, thanks to City Council, they have committed $154,000 or $57,000 for next fiscal year to pay for half of Arch's costs. The other half is coming from Mary Greeley, either the foundation or the medical center. And that's to expand the hours. It still will not be 24/7. That would be significantly more investment, but we really believe in it. That's for 1 year. Because Arch just started in October, and it had a 6-month pilot program, and it was so successful. The foundation provided additional money to get it to go to July 1, because our fiscal year starts July 1. That's when then we'll kick in our half of the money to help offset. I think you're going to
We'll be like
60 or 70 hours a week, I think it is, for two people.
7 to 11 Monday through Friday.
Yeah.
7 a.m.
Yeah, non-billable services, yeah. The other advantage too is that there's a close collaboration between law enforcement and Arch, and they're looking at how can they maximize, when do they get the most calls? And so they might be adjusting those the hours to make that work. So it's a great program. We're really thrilled to have it, and we just appreciate the leadership and the efforts. And just a quick example is that they responded to a call to a location. I won't say where it's at, where if there was lights and sirens, you normally would have, either a police or a, fire truck or ambulance responding. They pull up in a Dodge Durango with a little simple, logo on the side. Doesn't draw attention to what's going on. They can go in, engage, and then with two people being there, one person, in a situation, Leslie was able to talk to the individual, diffuse the situation, while the EMT, who provides medical support, if necessary, was able to engage with law enforcement in case they needed to come in. So it's just, I'm obviously, if you can't tell, I'm extremely biased. I think it's a phenomenal program. They're doing great work, and I think it's really helping meet the needs of our community. That it was one of the missing pieces. So,
can I add about mobile crisis?
Thank you.
So mobile crisis is accessed through One Life Iowa or 988. So, we didn't bring crisis cards because we thought Irely Ball was going to bring them. So we have a ton of those at our office. You have that down there. So you might see around in the school, in the library, little cards that say CICS crisis line. So what that is the number for One Life Iowa. It's the same number actually that you'll get to with 988. So if people are overwhelmed, anything where is a mobile or is a mental health crisis, if somebody's feeling overwhelmed and they can't cope with what's going on, and so they can pick up the phone, they can call that number, and there's going to be a live body on the other end that's going to help them, that's going to maybe just listen to them. And in that course of listening, if that person says, it can kind of get the feeling this isn't working, they are not de-escalating very quickly, they might need more help than what I can give them, they can offer mobile crisis to that person. They can say, I can dispatch a mobile crisis team to come to you. And they will come to your house and they can talk to you about this and help you maybe assess if there are more things that you need right now. So they can assess, like Arch can for the hospital. Does this person actually maybe need to go to ED? So we can assess if they need to be hospitalized. There's also some other programs in conjunction with that. They do like a crisis, a residential or a crisis community-based residential crisis kind of case management service. Like for 5 days after that, they'll have contact with that person every day to see how you're doing. Have you made appointments? Are you doing okay? Do you need more services? So mobile crisis can connect with more intense kinds of ongoing services that are not just the hospital. So you get to them in a totally different way. It's not a 911 call. It's through One Life Iowa, through 988.
And I'll add in there real quick. We've had a couple calls where we've collaborated with them where they are like an hour and a half out. So we actually go and start that intervention and then we hand off to them once they get there. And that's been really smooth. And then they can provide that additional 5-day follow-up, which is what we don't have that component with Arch, is that follow-up or anything after that initial contact. So it's been a really good collaboration on the calls that we've had.
All right. We have reached 8:30, and I think that the panel will be happy to stay and answer any questions you might have one-on-one. Thank you, panelists. We appreciate your coming. And Lindsay, thank you for your presentation also. Deb, thanks for helping orchestrate it. And again, June 6th, 6:30, this room will be our last session for the year. And again, thanks to City Council for their support. They have it's one of our values and goals for the year. And so with that, have a great rest of the evening, and we'll see you June 6th.
No.